Welcome, everybody. Is it working? Okay. Yep. So I'm very happy to see you all here. I like you all better than anyone else who's not in this room. I'm very annoyed with people who are not in the room. We have two lovely ladies presenting today, and I'm very excited about the series of talks of our adult care and child health researchers. And I think this presentation today is going to be a particularly interesting one. So we have Dr. Bethany Foster, who was wrongly named as associate professor. She is full professor at McGill University, a pediatric nephrologist and clinical epidemiologist. And her interest is in the outcomes of children and young adults with kidney transplants. She has funding from the CIHR and the NIH. She's known internationally. She does some extremely fascinating work. She has held all levels of the FRQS award, including senior scientist. And we're going to have a very exciting presentation by her. She has highlighted important differences in renal allograft outcomes by sex, and the magnitude direction can vary by recipient age and by donor sex. And I'd underscore that at the CIHR now, if you can't talk about sex and gender differences, go home, because nobody's interested. I'm just back from the RCT review committee meetings. And we have Ruth, Dr. Ruth Sapir-Pichhadze. So she is a transplant nephrologist, and she's a chercheur boursier clinicien junior 1. I know this because she's also late in applications, and so at the 11th hour, I was helping her enter her information. She is transplanted to us from University of Toronto because she realized McGill is, okay, I won't say this, I'm going to be broadcast anyway. But she holds she holds a PhD in epidemiology from the University of Toronto, and she treats adult patients. So her research focuses on the application of personalized medicine strategies for the prevention of immune-mediated injuries in kidney transplant recipients. She has this lovely presentation where she talks about Matchmaker, and it's fantastic. So she's interested in identifying genetic determinants of donor and recipient compatibility to optimize organ allocation schemes, because we know how valuable these organs are. And she is looking at personalized surveillance schedules and individually tailored therapeutic regimens in kidney transplant candidates and recipients. She's also a co-principal investigator on a large Genome Canada grant. So without further ado, I pass it on to Beth.
Thanks, Kabiri. Okay, so I'm going to start, and then I'm going to pass it on to Ruth. And you can see our title, and you've probably heard pediatricians saying that repeated and kind of annoying phrase, children are not just small adults. And like me, maybe you're sick of hearing that. So we turned it around this time. But really, the message is the same, that there are very, very large differences between people across the entire age span. And these aren't just differences in body size. There are important physiologic differences and behavioral differences that can influence many different health outcomes. And so while size is a factor, it's not the most important factor for sure. There are lots of other factors, and that's what we're going to be talking about today. And we're going to use the example of kidney transplantation, and I'm going to focus specifically on the example of the modifying effects of age and sex differences in kidney transplant outcomes. So the objectives today are first to demonstrate, I hope, that studying the entire age span helps elucidate mechanisms of exposure outcomes relationships in both children and adults. So on the adult side, we can actually learn a lot about mechanisms by studying children, and on the child side, we can learn a lot by studying adults. And I think by really taking those two together and looking at both at the same time, we can learn a lot of things that we wouldn't otherwise learn. As I mentioned, I'm going to consider the impact of physiologic and behavioral differences between children and adults beyond just body size differences, and I hope I might promote some integrated pediatric adult research, because that's what I do. Whoops. Okay. So this goes back to a few studies we did some years ago. We started out with kidney transplant recipients, and what we were interested in doing is just looking at how kidney graft failure risks differ by age. And what was novel about the way we did these studies was past studies always just talked about age at transplant and how things related to age at transplant. What we did differently is we made the data set dynamic, and we used age as a time-varying variable. So their age was updated as they were followed over time. So we were looking really at age-specific graft failure rates. And what these graphs are showing is the hazard ratio compared to the reference group, which is 21 to 24-year-olds, for other individuals of other ages for graft failure in kidney transplant recipients here. So you can see that the highest risk, the very highest risk of graft failure among kidney transplant recipients really happens in this interval between 17 and 24 years of age. So the emerging adulthood period, you may have heard it called, late adolescence, early young adulthood, whatever you want to call it, there it is. So we said, oh, that's kind of what we were expecting to see. But it's nice to see it. So we looked in the liver transplant recipients as well as in heart transplant recipients and really found pretty much the same pattern with the highest risk in that late adolescence, early young adulthood period. So that was very interesting. And as we were doing this, we thought, well, it would be kind of interesting as well to look whether there are sex differences. But before we go on to that, when we asked ourselves, well, why are we seeing this? Why are we seeing this high-risk period in late adolescence, early young adulthood? Most people blame it on adherence to their immunosuppressive medications. So all transplant recipients have to take immunosuppressive medications. If they don't take them, then they generally get a rejection and lose their graft. Or you treat the rejection. They don't lose it, but they need to take them. So that may play a role, and it probably plays a very large role, and much of my research focuses on medication adherence, so I must believe in it to some degree. But there's probably other stuff going on too. We do know that the immune system changes across the age span, and so we're starting to look in more detail to see whether there may be biologic reasons for this relationship as well. So we know, for example, that infants are born with a very immature immune response. And in fact, heart transplanters take advantage of this by transplanting across ABO incompatibility in neonates without any trouble at all, taking advantage of the fact that they have an immature immune response. We know that immune responses mature across childhood. And then after young adulthood, immune responses tend to dwindle off, a process known as immune senescence. So we know that there are decreases in the absolute number of T cells and decreases in naive T cells after young adulthood. B cells also decrease with age. Of course, memory cells, these are cells that have had exposure to antigens, increase with age. And we also know that there are major hormonal changes related to sexual maturation in puberty and aging related to menopause that can have an influence on these immune changes. So we became interested in whether graft outcomes differ by sex, and the reason we kind of became interested in this was partly because of the interesting physiologic changes that happen across the age span in different ways for males and females, but also because we noticed that in all the studies we'd done and that other people had done, when they were restricted to children and young adults, females tended to have worse graft outcomes than males in kidney transplant. But if you looked in studies that were restricted to adults, which are mainly older adults, they either saw no differences or they saw better survival in women than men. So what was going on here? Was somebody wrong, or were there actually real differences? So we started thinking about some of the factors that it can influence sex and gender differences in graft survival, and they're pretty complicated. Because in transplantation, you don't just have the sex of the recipient, but you also have the sex of the donor to consider. And so we need to think about whether there are actually interactions there between recipient and donor sex. The focus of this talk are there interactions by age. And then there may also be gender differences in medication adherence that also change with age. So there's many, many factors playing into this, and it's hard to sort of pick apart what's causing what, but we decided to try to look at this. So before we go on to what we found in our study, I thought I'd just review a few of the donor sex-related factors that can influence graft function and the recipient-related sex-related factors that can influence graft survival. So in kidney transplant, we know that male kidneys tend to have more nephrons, which are the filtering units of the kidneys. So just sort of simply, more nephrons is better. Also, the size of the nephrons in male kidneys tend to be larger. And so kidney transplanters talk about nephron dose. And a male kidney, in general, tends to provide a larger nephron dose, which, in theory, should survive longer than a kidney with fewer nephrons. There's also sex-related differences in body size. We all know men tend to be larger than women and therefore have larger kidneys. And this may also offer a survival advantage for kidney transplant. And then finally, there is a potential impact of sexually determined minor histocompatibility antigen, the HY antigen. So this is a protein that's present on all male tissues and no female tissues. And so a female recipient who gets a male kidney may recognize that HY antigen as foreign and mount an immune response against it. So there are potential interactions that have been described in the past. In terms of recipient sex-related factors, of course, females tend to have a smaller body size than males and therefore may put a lower metabolic demand on the organ. Therefore, it may last longer for females. There are also important intrinsic sex differences. So, in fact, the X chromosome, which males, sadly for them, don't have the most number of immune-related genes in the entire genome. And X inactivation is incomplete. So females may actually have a double dose of some of these genes compared with males. And some people think this may explain, or at least partly explain, the higher risk of autoimmune diseases in females compared with males, where the ratio is about 8-to-1 for autoimmune diseases. So there may be intrinsic sex differences that influence the immune reactivity, and sex hormones may also influence immune reactivity. In addition, there may be both intrinsic sex differences and sex hormone effects on the pharmacokinetics and pharmacodynamics of immunosuppressive medications. So what about sex hormones? How do they affect immune reactivity? So we know that there are receptors for sex hormones on many different immune cell types. And in general, we also know that estrogen tends to enhance immune activation, whereas androgens tend to suppress immune activation. Females produce more vigorous cellular and humoral immune responses to vaccines and to infections than males do, and that happens across the age span. So with the onset of puberty and the increase in sex hormones, this may contribute to a greater immunological risk in females compared with males. And sex hormones may also play into the pharmacokinetics and pharmacodynamics of medications. We actually have pretty much no idea about that. There's almost been no research on that. This is a nice figure from a really good review of sex differences in immune function across the age span, and I'm not going to go through it in great detail, just to say that both innate and adaptive immunity show differences between males and females at every stage across the age span, with greatest differences probably in this age interval and smaller differences in early childhood and also in older age groups. Okay, coming back to some of the interactions that there may be between donor and recipient sex. Like I mentioned before, that male kidneys may offer an advantage because of a greater nephron mass, and that's actually been shown in some large studies of adult kidney transplant recipients that a male donor seems to offer a survival advantage, but that female recipients don't seem to derive the same benefit from a male donor, probably because of the effect of the HY antigen. So that sort of counterbalances the benefit they might get from more nephrons. In terms of the body size effect, this is a nice study out of Halifax, where they used a large American database, the same one that I used for our studies. And what they have here is the different donor-recipient sex combinations, so male donor, male recipient, female donor, female recipient, and so on. And within each combination, they're looking at the mismatch in body size between the donor and the recipient. And before this study, many people had already shown that having a very small donor for a very large recipient is not such a good thing. And they re-demonstrate this, but they also then brought in the interaction with these donor-recipient sex mismatch, which was kind of interesting. So you can see that across all the different categories of combinations, body size, so the reference group is here, male donor, male recipient, where they're about the same size. As the donor gets smaller relative to the recipient, the hazard for graft failure increases, and that happens across each of the categories. And also, grafts where there's a sex mismatch between recipient and donor seem to have poorer outcomes than those where they're sex matched. But the very worst outcomes, in fact, of all of the different combinations are female recipients of a male donor where the female recipient is much larger than the donor, with a hazard ratio of 1.5. As I mentioned, there are also potentially important gender differences in medication adherence, and these may relate to beliefs, values, behaviors that determine medication adherence. And we did a small study in this. I'll show the results in a moment. We hypothesized going into it that there wouldn't really be differences in adherence in very young children because it's not up to them. The parents give the medications. And so there shouldn't be differences there. Whereas in older adolescents and young adults who are responsible for taking their own medications, we might see some differences there. And the previous literature has suggested that medication adherence would be better in women than men. There were a number of different studies suggesting this, although there are others that are conflicting with that. And when I say that, most people laugh and are like, duh, of course that's the case. But we weren't so sure what we would find, because we were seeing worse outcomes in girls, so we thought, well, maybe it's because they have worse adherence. So these are some data from our NIH-funded trial we did of medication, an intervention for medication adherence. But all these data were before the intervention happened, so it was in the run-in period. And we have patients divided into two age groups, so the younger ones and the older ones. And in the younger ones, so the males are the triangles, the females are the circles, there were no significant differences in electronically measured medication adherence between girls and boys. But in the older group, there were really quite striking differences, with the girls having about 3 times higher likelihood of having perfect adherence compared with the boys. So it was kind of what we were expecting for this group, and more striking than we were anticipating, but consistent with the literature for the other group. Okay, so now finally getting to our study of kidney transplant recipients. We looked at almost 160,000 deceased donor kidney transplant recipients recorded in the large American database. They had a median follow-up of about 5 years. And we compared graft failure by recipient sex, but considered the possibility that the sex differences may differ by recipient age and by donor sex. So a 3-way interaction, which is always fun. Like I mentioned in the very first slide I showed you, recipient age was a time-varying variable. So there were dynamic data sets. The patients' ages were updating as they moved through time. So this just shows crude graft failure rates by sex, not stratified on donor age. So you can see the pink is girls, the blue is boys. In the younger age intervals, there seem to be higher graft failure rates in girls and young women compared with boys and young men, but in the older age groups, nothing really going on there. When we stratify by donor sex, so these are all recipients of a male donor, female recipients, the young ones had higher risks than the young males, but no differences in the older age groups. And with a female donor, a fairly similar pattern, but the magnitude of the differences is much smaller. These are all unadjusted, crude results. So when we go on to the adjusted models, so these are the hazard ratios that came out from the time-dependent Cox models we used. Just to orient you, along the bottom, we have the current age categories. Here is the hazard ratio of death-censored graft failure. Ruth's going to talk a little bit more about what that means and how it may differ across age ranges. Suffice it to say, it's really capturing graft failures. That's what we want to capture, which are mostly immune-mediated. The circles are unadjusted results, and the little diamonds are adjusted. And what we're showing here is the hazard ratio for female recipients compared with male recipients when the donor is male. So you can see that female recipients had a significantly higher risk of graft failure than male recipients in all age categories, but the magnitude of the effect decreased with increasing age, which was not exactly what we were expecting to find. When the donor was female, it was a little bit different. Well, quite a lot different, actually. So, no effect in the youngest age group. Only in the 15 to 24-year-olds did we see significantly higher risks in young women than young men. Higher, but not significantly different in the 25 to 44-year-olds. And in the over 45-year-olds, women actually had a slightly lower risk of graft failure than men. And this sort of corresponds to the postmenopausal age period. So, as I mentioned earlier, there are a lot of different factors that can play into this. We made an effort to sort of try to summarize them and how they might change across the different age categories to explain the patterns we saw. So male donor, female donor, the different age categories and the different factors that might be playing a role. So among the youngest individuals, sex hormones probably aren't playing a very big role. You could argue that this is kind of an older age and they would be playing a role. I would agree with you. We did a sensitivity analysis restricting to kids under the age of 10, exactly the same results. So not a big role of sex hormones there. The HY antigen is going to increase the risk in females compared with males at every age category. That's not going to change. We didn't expect big differences based on adherence in the youngest age category, and maybe some intrinsic sex differences. So overall, higher risk in girls compared with boys. In this age group, a few differences. So now sex hormones may be playing a bigger role, and we may expect that better adherence in girls and young women may mitigate these higher risks in this age category. So overall, a higher effect. This age group, about the same sort of thing, maybe a less potent sex hormone effect. And then in the oldest age group, no longer having much of a sex hormone effect. And although the gene expression may be there, there is immunosenescence, so it's possible that all of these effects are of diminished importance as people get older. When the donor is female, everything is pretty well the same, except for, of course, there's no contribution of the HY antigen when you have a female donor and a female recipient. So in summary, factors contributing to the sex differences that we observe in graft failure risk probably include a contribution of sex hormones, maybe some intrinsic sex differences, certainly a reaction against the HY antigen. And I think learning these things may help us potentially come up with age and sex-specific immunosuppression strategies that might help improve outcomes. So I hope I've convinced you that studying the whole age range does help us potentially understand everybody better, not just children or adults, but the whole age range, and really help us understand what the mechanisms are. And I just wanted to thank my collaborators, some of whom are here in the room, and did a lot of this work with me. And I guess I'll pass it on to Ruth, and we'll do questions at the end. Yeah.
Put it over your ear and kind of. That's actually touching the cheek. Thank you. Okay, I'll just hold it. So thank you everyone again for being here today, and thank you for the opportunity to present alongside Beth the adult nephrologist or transplant nephrologist perspective somewhat. So indeed, adults are not just always big children, although we behave like that sometimes. So let me give you a little bit of context with regards to the continuum of care in patients who experience end-stage renal disease. By large, these patients are dialysis dependent, and here is an example for hemodialysis, but there are alternative modalities. Considering improved outcomes associated with transplantation, whenever a patient is deemed eligible to be waitlisted after a sequence of screening investigations, they are put on the waiting list awaiting the expected transplant. Most of the work that I'll present shortly is in the course following kidney transplantation. So subsequent to transplant, patients are typically followed over time with the hope of experiencing a good outcome where the graft will serve them for their entire lifetime. However, at times, patients might experience graft failure, and some might pass away while the graft is still functioning. So the context of transplantation has over the years been largely studied in the context of deceased donor transplantation. And this seminal work by Wolf et al. Truly demonstrated the advantages in survival, patient survival, in the context of transplantation, starting basically to be presented with an equal risk and eventually a superior survival over within a period of less than 1 year post-transplant. And this was done in consideration of a referent category where transplant recipients were compared with waitlisted dialysis patients with a similar waiting time since waitlisting. And this analysis was adjusted for various critical key variables, including age, sex, race, cause of end-stage renal disease, year of waitlisting, as well as time from dialysis to waitlisting. Those good outcomes were observed in what we now refer to as standard criteria donor transplants, and these were largely determined by age, namely donors younger than 60 years of age. Nevertheless, there's always greater demand than availabilities of organs for transplantation. And over time, there has been an effort to expand the donor pool. And the concept of extended criteria donor transplant was coined. And this work done by Ojo et al., published in the early 2000s, demonstrated that when looking at the ideal donor kidney, some of this would have been represented in the former analysis I presented, but when considering, in contrast, donors that are deemed more marginal, and this would have largely been determined based on age, the extended criteria donor scenario was associated, nevertheless, with improved survival for waitlist in reference to remaining on the waiting list on dialysis. And so the definition of extended criteria donor largely that was applied included donors who were older than 60 years of age, but also of a younger age group, 50 to 59, but with additional risk factors, including history of death secondary to a cerebrovascular accident, history of hypertension, abnormal or suboptimal kidney function. Over time, rather than this kind of a categorical variable of extended criteria versus standard criteria donor transplant, there has been an effort to look at risk associated with deceased donor transplantation a little more continuously, and an alternative risk scores are available, like the KDRI, limited with regards to their predictive value with regards to post-transplant outcomes nevertheless. So again, appreciating that the donor pool still is someone lacking with regards to meeting the demand for transplantation, as well as a growing appreciation of advantages of living donor transplantation. There has been an increase in advocacy towards pursuing transplants in this context. Some of the advantages have been shorter waiting time and shorter cold ischemia time. And so with this data from CORE, so this is Canadian data, on the left-hand side looking at the outcome of graft survival over time in the context of living versus deceased donor transplant, left and right respectively, we see an improved or a better graft survival in the context of living donor transplantation. So we've established that donor, in the context of deceased donor transplantation, donor age is associated with inferior outcomes or higher donor age, albeit better than remaining on the waiting list, and that advantage is very much appreciated. We sought in the following analysis to establish whether the living donor age also has an impact on kidney transplant outcomes. And this assessment across the continuum will be limited to both donors and recipients older than 18 years of age. So the main objective of this analysis were to determine the effect of living donor age on both short and long-term kidney transplant outcomes. We wanted to assess the impact of living donor age on graft survival while accounting for death with graft function as a competing risk. And you can imagine that the older the kidney transplant recipient, this may be a relevant competing risk. And finally, we wanted to better define the spectrum of risk when considering truly the combinations of both living donor as well as recipient age groups. So we conducted a retrospective cohort study, and you'll see that the Scientific Registry of Transplant Recipients is a quite popular data set to interrogate in the context of transplantation. The population of interest included consecutive kidney transplant recipients transplanted between 2000 and 2009. We excluded recipients who were younger than 18 years of age, and similarly transplantation in the context of living donors younger than 18 years at donation, multi-organ transplant recipients, retransplant recipients, and those that experienced primary non-function, basically patients in whom the kidney did not, the kidney transplant did not function and they remained dialysis dependent. So all of those were excluded. When considering the exposure of interest, and this was living donor age, we modeled it in two different ways. First, as a categorical variable, so beyond a referent group of 18 to almost 30 years of age, we created categories ascending by about a decade at a time, with the last category including living donors older than 60. And this variable was also modeled as a contiguous variable. Now, again, I described to you the transplant trajectory. So when thinking about the outcomes that we studied, subsequent to transplantation, short-term outcomes were considered DGF, or delayed graft function, that is defined as the need for dialysis during the first week following transplantation, and longer-term outcomes, including death-censored graft failure, as well as death with function. And commonly in transplantation, the two outcomes, death-censored graft failure and death with function, are also, graft failure, total graft failure in the context of either death or death with function or graft failure, usually combined as well. The analysis we conducted, in the context of delayed graft function being a categorical variable, we fit multiple logistic regression models for time to event outcomes. We conducted Kaplan-Meier and Cox proportional hazards analysis stratified by living donor age. We also modeled the relationship between living donor age and the survival outcomes using fractional polynomials to flexibly capture the relationship between exposure and outcome. Thereafter, we conducted several sensitivity analyses, and here I'll present primarily the analysis accounting for death as a competing event in the context of graft failure. So when looking at recipient characteristics, and those were taken at baseline, and baseline being at the time of transplantation, you see that across the living donor age groups, on the left-hand side, the referent category of 18 to 29, and going up in an ascending fashion to the living donor age category being greater than 60, we saw an increase in the age of recipients in the highest living donor category. Across age groups of living donor, the donors were primarily white. The cause of end-stage renal disease ascended with regard to the category of diabetes as a function of living donor age. And the proportion of preemptive transplant has also increased across the living donor age categories. When considering other donor characteristics, we see that female donors were the majority across the age group, and this is very well described in the transplantation literature. And again, the majority of donors were, majority of living donors were white. With regard to transplant characteristics, we looked at the type of therapies administered, donor-recipient incompatibility, but also the transplant era. And you will see over here that over the years, the proportion of donors older than 60 increased, with the most recent era having a proportion of 39.3. So let's look at some of our findings. So when considering short-term outcomes like delayed graft function, or as mentioned, the need to pursue dialysis in the first week post-transplant, we see a monotonically increasing relative odds of experiencing delayed graft function across ascending living donor age categories. When looking at the survival outcomes, so over here we have years post-transplant with the outcomes of total graft survival, death-censored graft survival, and patient survival with graft function from left to right, we see that the higher living donor age was associated with a greater risk of each of these time-to-event outcomes. When looking at the results of our Cox proportional hazards models, similarly, we see an ascending size of risk estimates, hazard ratios this time across the total graft failure, death-censored graft failure, and death with graft function categories, with a hazard ratio of 1.79 with living donors older than 60 in comparison to the referent category of less than 30 years of age. When the living donor age was modeled as a continuous variable with fractional polynomial terms, and the y-axis represented adjusted log hazard ratio for total graft failure, death-censored graft failure, and death with function from left to right, we see that there was an increased risk in the risk of each of these outcomes by ascending living donor age measured in years. And we see that across those figures, the more or less a threshold was identified in the range of 50 years of the living donor age. Finally, when considering death with graft function as a competing event to graft failure, the analysis demonstrated nevertheless a similar pattern whereby, again, across ascending living donor age categories, the risk of graft failure persisted, similar to what we observed in the Cox proportional hazards models. In this analysis over here, we went to further interrogate the combination of living donor age as well as recipient age and how that informs risk. So let me orientate you a little bit to this figure. And these diamond plots represent the following. So on the left-hand side, you see ascending recipient age. And on the right-hand side over here, ascending living donor age categories. So each of these cells represent a combination of particular living donor age and recipient category. The shaded region in each cell represents excess risk above a hazard ratio of 1, where this estimate is actually standardized to the lowest hazard ratio subgroup. So for this plot that looks at total graft failure, the referent category includes a recipient who is 40 to 49 years of age, transplanted from a living donor who is 40 to 49 years of age as well. And we see for total graft failure, which includes graft failure as well as graft loss from death, we see an increase in the risk or increase in the relative hazard, and this is most pronounced in the extreme of recipient age categories, so in the youngest and in the oldest recipient age group, so a U-shaped type of association, so to speak. When looking at death-censored graft failure, on the other hand, what we see there's the most prominent risk is observed in the context of the youngest recipient categories. And again, there is this kind of ascending risk or increasing relative hazard of death-censored graft failure across the living donor age categories. In the context of death with graft function, on the other hand, again, we see, starting from the second recipient age category, increasing risk of death with function, but this is most prominent, as expected, in the context of recipients who are 60 years of age or older. So in this analysis, we looked at a large national representative cohort. We interrogated the independent relationship between living donor age and kidney transplant outcome using multivariable models. We were able to estimate the impact of donor and recipient age category combination on transplant outcomes. But I also want to mention a few limitations of this particular analysis, starting from the fact that those inferences could be drawn in the context of the population of living donors that were deemed suitable for transplantation or were selected for transplantation. A second issue, as with all observational studies, although we pursued multivariable analysis, there's still a possibility for residual confounding. And finally, although the analysis informs decision-making and can facilitate patient counseling to a certain extent, in fact, in the transplant scenarios, what we're interested in is the advice with regards to whether it's worthwhile waiting for a age-compatible, potentially deceased donor transplant or pursue living donor transplant. And those analyses have been conducted subsequent to this analysis. And in general, the living donor option, even at the extremes of age, is deemed the preferred strategy. So To summarize, and here I'll venture to summarize some of the observations related to age that Beth presented to you a short while ago, as well as so across the age continuum, including pediatric as well as in the adult context. The consideration of age across its continuum truly informs on mechanisms of graft failure. Unique to transplantation, and I will start there, that in the matchmaking games that we pursue, we are considering not only recipient characteristics and within them recipient age as a risk factor, but also donor characteristics. And graft health or graft senescence has been shown to be associated with transplant outcome. At the level of the recipient, again, Beth alluded to the importance of immune reactivity potentially and the opportunity to taper immunosuppression to individual patients' needs, and those this can be guided by the patient's age to some extent. There's evidence to suggest that drug handling may be modified by age. And evolves with patients' growth or aging. The concept of competing risks, we handled this in this particular analysis, but as you can imagine, with age and extremes of age, we see a greater comorbidity burden and potential for frailty to inform kidney transplant risk as well. Finally, with regards to how to model risk associated with age, and I've presented to you analysis where age was modeled as a continuous variable, and we typically do try to model exposure this way, trying to maximize power in our analysis. But there are scenarios that modeling it as a categorical variable might be informative as well. For example, when it aligns with growth and development over time and hormone secretion patterns. Lastly, in the analysis that Beth presented to you, as age post-transplant was captured as a time-dependent variable in a dynamic fashion. And this may be appropriate modeling in the context of post-transplant scenario. At the time of organ allocation, on the other hand, the decision needs to be done then and there. And in the analysis that we presented to you, when considering the donor age specifically, age was modeled as a time-fixed variable. So I will conclude our discussions as follows. We find age to determine risk in a multidimensional fashion, and its careful consideration in the context of study design analysis may help inform personalized patient care. I'll thank you for your attention, and I'll invite Beth to join me, and we'll take some questions. So in general, living donor transplants are superior to deceased donor transplants. Absolutely compatibility or history of whether you're dealing with a related donor versus unrelated donor has an impact with regards to outcome. The most extreme scenarios would be where, even in the context of related donors, if a transplant recipient has antibodies against the donor, they would experience inferior outcomes, and this is a context of high immune risk transplants. But the greater the compatibility at the level of the HLA, the outcomes should be superior. So in this particular analysis, what we did was we adjusted for HLA incompatibility whether the donor was related to the recipient or not was not. We didn't stratify based on that analysis.
Can I add something?
Sure.
Yeah.
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 So you said you can have antibodies against your sibling?
So you may, so again, think about it this way. Think about it this way. We get genetic information from both parents, and there is so 25% of the time, depending on the again, depending on the genes that we are considering, there's likely that the compatibility could be greatest, but there's still the potential that there is incompatibility, of course, even in the context of living-related transplants. So the ideal scenario when we do this kind of testing would be to verify that the HLA types of donor and recipient are the same.
Can I add something?
Sure.
But unrelated donors, living donors, still give excellent outcomes and better than deceased donors. And also, the relationships are really complex with related donors, which is why all the stuff I presented, we restricted it to deceased donors, because when you start getting into living related donors, particularly if the mother is donating to a child, those grafts may actually have better outcomes because the child gets exposed to some maternal antigens in utero and then may develop tolerance to those. So there's actually evidence that maternal child grafts may do better than other types of grafts. So then when you throw that into the mix with like donor recipient sex and the whole thing, it just becomes like a big mess. So we haven't looked at that yet, but I suspect we'd find different things.
So, you know, the question that's coming, Ruth, did you look at sex in your analyses, or are you thinking about looking at sex?
So in this particular analysis, again, sex was was handled as a covariate, and we considered both donor and recipient sex. But the analysis that Beth presented did stratify by donor, by recipient sex, and there's an analysis stratifying by both donor and recipient sex, and then adjusted for age as a time-varying variable.
So based on Beth's findings, do you think that there is potential for effect modification by sex in the adult?
So why don't I let Beth respond to that?
Do I think there's effect modification in what relationship? Sorry?
What Ruth presented. So here it was sex as a covariate, but obviously that's different from what you showed, which was sex as an effect modifier.
So is sex modifying the relationship between donor and or recipient age and graft outcome?
Yeah.
Could it? Yeah, it could.
I knew the answer to that question, but
again, I think it comes into the living related donors, and depending on what the relationship is, because if a woman who's been pregnant in the past needs a transplant, then she is more likely to have sensitization because she gets sensitized, of course, to the fetus. So she, even if it's unrelated, in fact, or non-biologically related, she's more likely to be sensitized to the children's father, right? Because the children have half the father's antigens, so she may be sensitized to the father, and also to her own children. So I guess that could influence something.
There's a lot of good grants you guys have to write together. Any other questions from the audience? Well, thank you for a fantastic dual presentation. I know everybody's going to walk out of here better informed, better researchers, and better than everybody who didn't attend. So please spread the word.